Hi everyone, I am Dr. Windsor. Thank you for listening to my lecture that will cover the first half of Chapter 1 in your Surgical Technology for the Surgical Technologist textbook. Well, we have a lot to unpack, so let's go ahead and get started. There are a few things that we should be able to do by the time we get done with talking about this half of Chapter 1. We should be able to define and describe what effective communication looks like in the surgical setting, as well as have an understanding of the historical development of the field. We'll also be able to identify surgical team members and what their roles are in the surgical setting, as well as identify career opportunities and a variety of employability, or as I like to call them, soft skills. First, let's start off by talking a little bit about the history of surgery. Now, the Western world is what we're going to be focusing on, and that gives us a broader overview of the history of the development of medicine and science and intellect. So let's start off by talking a little bit about the classical period. The classical period was between the years of 1750 and 1820. It's known for intellectual contributions to society. So philosophers like Aristotle and Hippocrates. You may have heard of the Hippocratic Oath. That was Hippocrates. They were really influential, and during this period, the first steam engine was invented. We also saw the first Encyclopedia Britannica, and then there was the discovery of vaccination by one Mr. Edward Jenner, who first developed the smallpox vaccine. Now, in the Middle Ages, they kind of break it up into three periods: the early, the middle, and the late. And this was around 500 to 1500, and it began with the fall of the Roman Empire. It ended with the Renaissance era. Here we find the establishment of government. There was war and famine and pestilence, and there was also the birth of the first university. Most importantly to us, modern theories evolved pertaining to the human body. In fact, Andreas Vesalius was nicknamed the father of human anatomy for his series of books that he wrote, and they were titled De Humanin Corporis Fabrica Librae Septem. This translates to On the Fabric of the Human Body. So this was a series of 7 books that he published, and this was huge because it completely overthrew 1,500 years of previously established anatomical teachings. However, modern surgery as we know it now was not possible at this time. In fact, the 19th century was when surgery really started to appear, so much so that historians refer to the 19th century as the birth of surgery. And during this time, physicians performed different procedures like the first blood transfusion. If you've ever seen that red and white barber pole, that long time ago, barbers would put outside to signify that they did something called bloodletting. And they used to think that when somebody was sick, they needed to let out the bad humors, quote unquote, and they would let out people's blood, thinking that that would help them get better. What else did we see during the 19th century? The first hysterectomy, so removal of the uterus, the first removal of the appendix, and also the first open heart surgery. That's so amazing. And X-ray was also discovered then as well. So as you know, major advances have carried into the 20th and 21st centuries and has become what it is today and what we will mainly focus on as you go through your program. Now, non-physicians and nursing assistants they've been involved in surgery since literally the beginning. If you take a look at Table 1-2 on page 5 of your textbook, you're going to see that Mr. Rampley was the first documented employee in the OR in the late 19th century. Instead of being referred to as a surgical technologist, he was referred to as a surgery beadle or theater technician. Now, in 1948, Britain formed an organization called the Operating Room Theater of Technicians, or ORT for short. The early development of the role of the surg tech in the United States parallels that of Britain, and in World War II, the majority of the men were sent out to the battlefield. So this left mainly the physicians and the nurses in the hospitals. So the nurses started assisting surgeons. They trained them to assist in surgery. Hence, we get the term scrub nurse. Some old school surgeons will still refer to us surg techs as scrub nurses. In the beginning, many OR techs were trained in the military, and they still are to this day. In 1959, the first ever published publication, regarding the role of the surg tech was published by the American Hospital Association. And the second publication came out in 1967 and was written by the Association of Operating Room Nurses, or AORN for short. Then, fast forward a short little minute in time, and in 1970, certification was selected over licensure, and the first certification exam was given. Interestingly, my good friend Linda was one of the surg techs that took that exam in 1970. In 1974, the Liaison Council on Certification for ST became an arm of the Association of Operating Room Technologists responsible for certification. And it wasn't until later that year that ARC-ST, the Accreditation Review Committee for Surg Tech, was appointed. This gave way to the beginning of standardized and formal education training for us as surgical technologists. Then, a few years down the road, 1978, the Association of Operating Room Technicians changes its name to the Association of Surgical Technology, AST. That is what we have still to this day. The first edition of what we call the core curriculum was published in AST in 1981, and we'll mention that again a little bit later. Just this year, AST published the 7th edition of the core curriculum and brought it up to date. It's been quite a few years. So when I started teaching in 2010, we were just starting to implement the 6th edition. So it's been a little while. It was due for an update, and they just came out with that. Now, along the way, AST has also published a code of ethics for surgical technology, and the associated degree for surgical technology was also introduced. Standards of practice were adopted through the combined efforts of the American College of Surgeons and the Association of Surgical Technology. And the role of surgical assistants was also defined. And then in 2006, LCCST, which was the Liaison Council, changed its name to NBSTSA, which it is today. And that stands for the National Board of Surgical Technologists and Surgical Assistants. And lastly, to kind of sum up our historical look at surgical technology, in 2009, ARC-ST changed its name to ARC-STSA and incorporated surgical first assisting under its wing. Now let's talk a little bit about the surgical team. the four primary members of the surgical team include the anesthesia care provider. Sometimes we shorten that to ACP. The circulating nurse, the surgeon, and of course us, the surgical technologist. In addition to these, there might also be an assistant that's helping out, and the assistant can be a surgical first assist or perhaps a physician's assistant or even another doctor. The anesthesia care provider and the circulator are referred to as the non-sterile team members, and the surg tech and the first assistant and the surgeon are the ones that remain sterile throughout the procedure. So there's a variety of other individuals that you may encounter in the operating room that are not sterile, like individuals that come to take x-rays intraoperatively from the radiology department. Maybe there's different vendors that the doctor is using their medical device, and so they're there to kind of support the team for that. And there's other hospital personnel as well that you'll kind of learn as you go through. And for now, we're just going to focus on the four primary members, and I'm going to give some examples of each of these surgical team members' duties in the upcoming slides. First, I just want to talk about the three phases of surgery. Surgery has three distinct phases: the pre-operative phase, which is the before a part of surgery. The second phase is the intraoperative phase, which is the part that where surgery actually happens. And then the third and final phase is the post-operative phase. So as you make your way through the program, you'll learn more about the details. We're just going to kind of give I'll give an overview in regards to the surgical tech and their duties within those three phases, but you'll learn more about each of these and what each of the individuals do in each of those phases as we go along. And of course, my favorite part is the intraoperative part, because that is where all the magic happens. That's the fun part. All right, now the non-sterile team members' duties. Let's talk a little bit about that. So take a minute and see if you can recall the two primary non-sterile team members. Remember, they are the anesthesia care provider and the circulating nurse. So take a look at the top picture. Which one do you think is the anesthesia care provider? Why do you think that? Who do you think the other person is? If you said that the person on the left is the anesthesia care provider, you would be absolutely correct. So great job. The anesthesia care provider often has an assistant called the anesthesia tech, and that is the person on the right in the picture. So let's discuss some of the responsibilities of the anesthesia care provider. The anesthesia care provider is responsible for meeting with the patient before surgery, and they do an assessment. They have a checklist. There's things that they ask them. They look at their airway. They ask them if they've ever had surgery before. Do they have any allergies? Did they have any problems with surgery? So on and so forth. So they assess the patient, and then they make the determination of what type of anesthesia is going to be best for the patient in regards to the physiological status of the patient, as well as the procedure that will be done. And sometimes they confer with the surgeon as well. They're also going to discuss the risks and benefits of that anesthesia plan with the patient. And they're going to weigh in on patient positioning as well. And during surgery, they're going to manage the anesthesia care throughout the entire procedure. So they'll be the one that comes into the OR with them and stays with them the entire time. And their job, if the patient does have a tube that they're breathing through, they're going to support that airway and also administer fluids throughout the procedure. So that's the anesthesia care provider. Let's talk a little bit about the bottom picture now. So take a look at the bottom picture. Which one of these ladies do you think is the circulating nurse? The one on the left or the one on the right? She is the one on the right holding the clipboard. See it there? Notice that she's not wearing a sterile gown like the individual on the left. So who do you think the individual on the left is? If you thought that's the surgical technologist, then you're right. Great work. The circulating nurse has a lot of responsibilities and is really our partner in the operating room because they help us get the OR ready. So in addition to that, let's talk a little bit more about what they do. I already said that they help us get the OR ready. So we're going to be paired up with a circulating nurse. We're going to work with that individual for the whole day. Now, it might change within the day, but typically not. Typically, it's one surg tech and one circulating nurse assigned to a room, and they do all of those procedures in that room that are assigned for the day. And then you might have a different circulating nurse the next day, or you might have the same one. Now, the circulating nurse is going to help us get all of our supplies, get everything ready, help us open everything. They're also going to ensure that documents and reports are available. So if there's x-rays or, is there a history and physical on the chart, those kinds of things. They're going to take a look at that and make sure it's all in order. They will also participate in the pre-operative interview. So I already said before that the anesthesia care provider interviews the patient before surgery. The preoperative nurse will be there as well to participate in that interview and ask their various questions. One really important question is, when was the last time that they ate, right? If they grabbed a Snickers bar on the way into surgery, we're not going to be able to do their surgery right away because they have stuff in their stomach, and that could increase the chance of contents from their stomach getting into their airway while we're putting them to sleep. So they're going to ask that, they're going to ask their name, they're going to make sure, confirm the procedure that they're having, so on and so forth. Then they're also going to help transport the patient to the operating room from the preoperative area and then to the postoperative area after surgery. Once we get into the operating room, the circulating nurse is going to help get the patient over onto the OR table. They might assist with putting the patient to sleep if there isn't an anesthesia tech available. And then they're going to position and prep the patient. They're also going to give us supplies intraoperatively as we need them. So if we need more sponges or another stitch or an instrument fell on the floor and we need another one, they're going to help us with that. They're also going to connect any sterile cords or tubes that we are using. Maybe we're doing some sort of minimally invasive procedure that requires a camera. So they might be hooking up the camera, the light source that's associated with that, the suction, the cautery, those kinds of things. They're also going to do intraoperative charting. And we will pass off any specimens that the surgeon takes during surgery. We will pass them off to the circulating nurse, so they're going to prepare those and get those sent on their way. They're also going to come and secure the dressings after the surgery is done. And lastly, but surely not least, they are going to help with the turnover. So the turnover is the time from when the patient is out of the room till the next patient comes in. So basically cleaning up the room, getting it ready to go again, bringing in the supplies for the next procedure, and then the process just kind of starts all over again. So let's talk a little bit about sterile team members. Can you recall the three primary members that I listed previously? Think about them. Remember, I said that they are the surgeon, the surgical tech, and the assistant. Now, there can be more individuals at the field, but these are the primary ones. So look at the top picture. Which person in this top image would you say is the surgeon? The surgeon is actually the person on the left. Which person in the image would you say is on the right? How did you know this? For me, I noticed that the person on the left is holding a scalpel and the surgeon makes the incision. And the surge tech often provides exposure for the surgeon during surgery by holding retractors. And you can see that there's some sort of metal devices in this individual's hands. So I am assuming that this is the surgical technologist. So let's talk about the surgeon's duties specifically. The surgeon can be a medical doctor, or they can be a doctor of osteopathic medicine, which we abbreviate as DO. They can also be a doctor of podiatric medicine, a DPM, or a doctor of dental science, a DDS. Now, the surgeon sits at the helm of the ship and they steer the surgery. All right, they help determine what type of surgery the patient's going to have, and they also have a discussion with the patient about the risks and the benefits and various alternative treatments so that the patient makes sure that they have a say in their care as well. They also decide the correct surgical site, and they also participate in something called the timeout. The timeout is performed right before we make the incision. So we'll all just kind of collectively discuss, is it the right patient? Is it the right procedure? Is it the right side? If we're doing a left hip or a right hip, let's say. So they participate in the timeout. And let's see, what else do? They perform the procedure. So they're going to be the ones doing the procedure. They're also going to be the ones guiding us. Remember, I said the surgeon sits at the helm of the ship. We're literally working under their guidance. And they're also going to provide that follow-up care post-operatively after surgery for the patient. Now, let's look at the bottom image. And it looks like we have 6 individuals in this image. Where's the first assistant? I'm going to give you a minute to look over the image and decide which number represents the first assist. Okay, do you have your number picked out? Which one did you pick? Survey says the FA is number 2. Can you identify any of the other team members? We're going to talk through each one of them. The CST is in the number 1 spot. And that's fitting, right? CSTs are number 1. We know that. I determined this because of the orientation of the Mayo stand. So if you look at that blue tray that's coming over the operative field and it has some instruments on it, we call that the Mayo stand. And we'll talk more about the specific duties of the CST on the next slide. For now, we're just going to focus on the first assist. So once I identified that the CST was number 1, right, that also helped me to determine number 4. Number 4, which is the surgeon. The surgeon typically is across from the surge tech, or rather I should say it this way. We position ourselves across from the surgeon in most instances, not all times, but typically we stand across from the surgeon during surgery. So number 4 is the surgeon. He also has a marking pin in his hand. It looks like he's marking the incision. So that gave me another clue. So that brings us to number 2, the first assist. Now, the first assist typically also stands across from the surgeon because it's easier to assist in this orientation. Now, the FA may be a medical doctor as well. They can also be a doctor of osteopathic medicine, or they can be a certified surgical first assistant. Now, some of the things that they do is they help with positioning, so they can help the circulating nurse with positioning. The surgeon is sometimes in there assisting with positioning as well, and they also help with draping, as does the surgeon. Sometimes it's you and the first assist that's doing the draping. Sometimes it is you and the surgeon. Sometimes it can be the surgeon and the first assist. But all 3 of these sterile team members can assist with the draping. They also participate in the timeout. And if they are there, instead of us providing most of the exposure, that's going to fall to the role of the surgical first assist. So they will assist with providing exposure, suctioning the wound so that there is visibility of what the surgeon is working on. They might also do some sponging. All right, so you want to make sure you always have a sponge on the field too, I would suggest. They also assist in the identification of anatomical structures and landmarks. Is there another pair of eyes for the surgeon? They also assist with hemostasis. What is hemostasis? Hemostasis means the stopping of heme, or blood, right? So hemostasis is the stopping of blood. We don't like to lose blood in surgery. So there's a variety of ways that we stop bleeding. It could be clamping it, could be cauterizing it, could be using some sort of chemical, pharmaceutical agent. Anyways, they're going to help with that. They're also going to close the wound, perhaps. They'll also help with applying dressings, and they will also assist with moving the patient from the OR table back to the gurney for transport to the post-operative area. Now that we have a better understanding of the various roles of the surgical team, we should be able to quickly identify the surgical technologist in this image that you see on your screen. So take a minute to decide which number you think represents the surgical technologist. Is it number 1? What about number 2? Do you think the surg tech is number 3, or are they number 4? Why are you picking this number? Well, the correct answer is number 4. That's the surgical technologist. So if you were thinking that, fantastic job. Number 1, that's going to be the surgeon. All right, you see number 4, the surg tech is passing an instrument across the table to someone. That's typically going to be the surgeon. So number 1 is the surgeon. Number 2, peeking over the drape there, that's the anesthesia care provider. Number 3, standing directly across from the surgeon, that's the first assist. And then number 4, that's us. Right? So as I mentioned before, the CST performs many duties throughout all 3 phases of surgery, the preoperative, intraoperative, and postoperative phases. So let's talk about each of these briefly. We're going to start with the preoperative phase, which is the before surgery part. So during this time, the surg tech is gathering the necessary equipment and supplies. If there's a case cart with the supplies on it, we're the ones responsible for bringing that in, and there's going to be something called the preference card. And the preference card I like to think of as the recipe for surgery. If you're going to bake a cake, you get out your recipe. If you're going to do an appendectomy for Dr. Smith, you get the preference card. All right, it's the recipe for surgery. So part of our job preoperatively is to look at that preference card and look at the stuff that we have and make sure the two are aligned. If anything is missing, it's our responsibility to get whatever is missing. All right, so once we make sure that we have all of our equipment and supplies, we're going to review the patient info, right? And make sure that we know what surgery we're doing, what side we're doing, so on and so forth. Is the patient there? Has the patient ate? We don't want to open up our sterile field if the patient isn't in-house, or if the patient has had something to eat. We might need to delay that case, and we don't want to just leave sterile stuff open and unattended. So we want to make sure that we check the patient info. We're also going to arrange the furniture in a way that allows us to start creating the sterile field. We're going to open all of our supplies, right? The nurse is going to help us. And once we get done with that, we're going to go do our surgical scrub. Once we do our surgical scrub, we're going to come back into the operating room and we're going to put on, we call this donning. We're going to don our sterile gown and gloves. Then we're going to proceed to organize the field. We opened a bunch of stuff on it, right, when we weren't sterile, and now we are sterile. So now we can touch all of our sterile stuff and we can arrange it and make it look really pretty. The nurse is going to be there with us, right? They're going to be giving us the medications that we're going to be using intraoperatively, if there are any, or any fluids we're going to be using for irrigation. And our responsibility will be to verify and label those. And you'll learn about that process as we go along. We're also going to count the stuff that we have with the circulating nurse. Why do you think we count? Well, patients get kind of upset when we send them home with little gifts inside them. So we want to make sure that we don't leave anything in our patient, a sponge or an instrument or anything like that. So we're going to count what we have before we even start preoperatively. This gives us an initial base count. All right, so we're going to do that with the nurse. And when the time comes and the surgeon and the first assist are there, we are going to put on their gown and put on their gloves, all right, for the other team members. We're also going to assist them, like I said before, with placing the sterile drapes. And then we're going to move all of our stuff up near the patient because now they become the center of the sterile field once we have those sterile drapes on them. And really, really important here, we're going to maintain the sterile field throughout. As soon as we establish the sterile field, it is the primary responsibility of the surgical technologist to maintain that sterile field. That means don't let anybody contaminate it. Don't let anybody who's not sterile lean over it or get too close or touch it or anything like that. And if something does happen, we are quick to recognize it and quick to fix it. All right? Now, once the field is draped, let's talk about that. Once the field is draped and the sterile team members are at the field, this is when the intraoperative phase starts. All right? So now we're going to have the timeout. Just before we cut or poke the patient, we're going to do a timeout. So we all stop. We stop moving. You're not doing anything during the timeout. We're going to verify that this is the right patient, the right procedure, the right side. If there is a right or left side, we're going to verify that everybody says yes, they're in agreement. You might also say any implants that you have on your field, what medications you have on your field. They're also going to verify allergies and some other important pieces of information. You might also be establishing something called a neutral zone. This is a place where sharps are deposited so they are not transferred hand to hand. Now, some surgeons go for that and some surgeons don't. Biggie here is anticipating the needs of the surgeon and the team. Basically, as the surg tech, you need to know what the surgeon needs before the surgeon knows he needs it. That is our job. It is the game we play every single day, anticipating the needs of the surgeon and the team. Also passing those instruments correctly and on time right? So that they can use them right away, and giving them the supplies that they need. Do they need more sponges? Do they need a stitch? Do they need a different suction tip? Do they need a longer cautery tip? Whatever the case may be, anticipating those needs. It's kind of like when you make a peanut butter and jelly sandwich, all right? You can anticipate how that's going to go. You're going to need 2 pieces of bread. You're going to need your peanut butter. You're going to need your jelly. You're going to need a knife, right? So you're going to need a plate. So you get all of those things out, and then there's steps that you follow to get to the point where you have a peanut butter and jelly sandwich. It's the same way. It takes time to learn to anticipate the needs of your surgeon. You'll learn some basic principles of anticipation as you go throughout your program and progress, and then you get into clinicals. It just is a continuous learning component of being a surg tech. So be gentle with yourself, give yourself grace as far as anticipating the needs of the surgeon and the team. Passing medications and irrigation fluids. So any medication that's used intraoperatively, whether it's in a syringe or it's in a graduate or whatever, we're responsible for passing that to the surgeon, and importantly too, keeping track of how much is used during surgery, because we're going to have to report that to our circulating nurse at the end. We also do more counting intraoperatively. We want to make sure that we are leaving with what we started with, right? We had 10 sponges when we started. We want to make sure we have 10 sponges at the end to confirm that we didn't leave anything inside of the patient. We're also going to be handling those specimens. So if the surgeon takes out the gallbladder is going to get handed to us, and our job is to label it, to make sure that we know what it is, and to have an understanding of how the surgeon wants it sent to pathology by itself in some fluid, whatever, and then to make sure that it's okay with the surgeon to pass it off, and then we're going to give it to the circulating nurse, and then they're going to do whatever they do with it. We can also help with cleaning up afterwards, like the skin might have blood or prep solution or whatever on it, so we kind of help clean that up. And then prepare the dressings and sometimes place the dressings. All right, now these are just nutshells, folks. It's not like every single detail, but this gives us a good overview of the preoperative part. So let's talk about the postoperative part. Once the dressings are placed on the wound, and we want to keep the wound covered so it doesn't get contaminated, so we put sterile dressings on there. That is the end of the intraoperative phase, and we move into the postoperative phase. So during this time, the surg tech is going to push back their furniture, right? You have your sterile table, you have your Mayo stand, you might have a ring stand that's sterile. You're going to push all of that stuff back and make sure that it stays sterile until the patient has left the room. Now, once the patient is out, we're going to proceed with breaking down the sterile field. So this consists of discarding any trash that we have that's just a single-use item. We're going to get rid of any of those things in the biohazard trash. And then we're going to disassemble all of our instrumentation, open all of our instrumentation, and separate it clean from dirty. So clean meaning it stayed on the back table and didn't come up to the field and come into contact with the patient's tissues. Dirty meaning it did come into contact with the patient's tissues, and we kind of need to separate those, right? Here's the example. You plan for a dinner party of 20 people and 15 show up, but you have 5 clean place settings, but you have 15 place settings that were used. So before you put them in the dishwasher, those ones that were used, you might want to give them a little bit of an extra scrub before you put them in the dishwasher. But the ones that were there that weren't used, you really don't need to give them an extra scrub. So you can go ahead and just put those right into the dishwasher without soaping them up or wiping them up first. And this is kind of the same principle here. We're getting ready to take this instrumentation to the decontamination area so that they can clean it, re-sterilize it, and put it back on the shelf so that we can use it again the next time that we need it. All right, so we're thinking forward to help out our peeps in the decontamination area. So once we get our instruments all disassembled and separated, we're going to take them to the decontamination area. And then we're going to come back to our operating room and we're going to help with that turnover that I mentioned before. We're going to get the room cleaned, wipe the beds, mop the floors, whatever we need to do, get the bed redressed, get new bags in the receptacles, and bring in our stuff for the next case. All right, we're moving along here. We're about halfway done, so hang in there with me. We're going to talk a little bit about the areas of specialty and the classification of procedures. So I mentioned before the American College of Surgeons. Remember, they partner with the Association of Surgical Technologists to determine what basically our scope of practice is. All right, so according to the American College of Surgeons, there are 14 recognized surgical specialties. And if you turn in your textbook to page 9, you can look at that list with me right now. And it's important to note that certification in specialty areas is required to qualify a physician to treat patients in that specific specialty. Many of those specialties are further broken down into subspecialties like pediatrics, geriatrics, bariatrics, trauma, so on and so forth. So, let's say you want to become an orthopedic surgeon. You would need to complete 4 years of pre-med, 4 years of medical school, and then multiple years of residency to gain experience in your specialty area of orthopedics. Then you will need to pass the board certification exam for that specialty, and voila! You are an orthopedic surgeon and you can start operating on people. So here's a list of common specialties. At the top of our list is general. Example, hernia repair. Orthopedic surgery. Example, joint replacement, like a hip or a knee. Genitourinary, we often abbreviate GU, and that has to deal with the male reproductive system and the male and female urinary system. So this could be a bladder biopsy. This could be an orchiectomy, which is the removal of a testicle. It could be something like that. Neurosurgery. Here we're talking about the brain. All right. Do we need to remove a tumor? Is there too much fluid on the brain that we got to put a drain in to drain off? Maybe something with the spine as well. Is there a herniated disc, or was there a trauma and there's a fracture and that needs to be fixed, a fracture of the vertebrae? Cardiothoracic, dealing with heart and things within the chest cavity that live near the heart, all right, like the lungs. So cardio, that could be a valve replacement of the heart, right? Or it could be some sort of bypass graft if we have an artery that supplies the heart with much needed oxygen, has a blockage in it, we can bypass that. Thoracic being perhaps the lungs, all right? Maybe there's a tumor, we have to remove a lung or something like that. Peripheral vascular surgery. Here we're talking everything except for the heart and its main vasculature. So anything else, the veins that go down the legs, the main vein is the saphenous vein, or it could be the femoral artery, or any tributaries that lead away from and back to the heart. All right. A lot of times these surgeries are to bypass an artery that's blocked, and so downstream we're not getting the blood flow that we need, and so the tissue is not able to live. So we need to bypass. We need to put a little tributary, right, to go around. So that limb can get blood that it needs. Otorhinolaryngology. Say that 10 times fast. That is why we call it ENT, ear, nose, throat. All right? So oto means ear, rhino means nose, larynx is our well, it's our larynx, but it refers to our throat. So here we might do a tonsillectomy, remove tonsils, or we're doing something with the nose. All right, maybe there's growths in the nose, in the sinus cavities, and those need to be removed, something like that. Then we have oral and maxillofacial surgery. The first thing that comes to mind here, and there's a variety of procedures, but maybe like a fractured bone that's right below the eye, right? The orbit, something like that. And then we have obstetric and gynecology. So obstetrics is specifically dealing with welcoming new humans into the world. All right, I call those birthday parties. Those are really fun. And then gynecology is the care and treatment of the female reproductive system. So hysterectomy, removal of the uterus, or oophorectomy, removal of the ovary, something like that. Anything that has to do with the female reproductive system, both internally and external genitalia as well. And then that brings us to plastic and reconstructive. Plastic surgery is... When I think of plastic surgery, I think about tummy tucks. I think about, we call that an abdominoplasty. I think about nose jobs, which is called a rhinoplasty. I think about breast augmentations, which would be like a boob job, okay, we call it on the street. Reconstructive is a little bit different. Maybe there's been a cancer removed from the jaw or the face, and that needs to be rebuilt and reconstructed, something of that sort. So that's it in a nutshell. So along with surgeries being divided into specialties, they're also described according to their classification, and there's 3 categories that help us to prioritize patient care. And those include emergency, urgent, and elective. So emergency procedures. This could be like a ruptured appendix or a ruptured ectopic pregnancy. These require immediate surgical intervention to save a life, right? This category also could include a variety of trauma situations that either do or do not occur during motor vehicle accidents, like a ruptured spleen. Urgent procedures, on the other hand, require treatment within a short period of time. Examples would be ectopic pregnancy that has not ruptured, or we have a patient that we've diagnosed with appendicitis, but the appendix is not ruptured. Then the last category is elective. Now, these procedures are planned and non-emergent. Think joint replacement surgery, or they're optional. Breast augmentation, facelift, which the medical term for facelift is rhididectomy. So each and every procedure, just to reiterate, that we do has a pre-op, intra-op, and post-op phase. And when we are referring to all 3 of those phases together, we call that we call that perioperative. All 3 phases, perioperative. Now let's get into some more details regarding the profession of surgical technology. Now, surgical techs, we are referred to as allied health professionals. What does that even mean? That means we're specially trained healthcare professionals that aren't doctors, dentists, or nurses, basically. We are usually licensed or certified in our field of practice, and as surg techs, we work directly under the supervision of the surgeon, and we play an integral role as part of the surgical team. And we talked about that already. Surgery could not and would not happen without us. Obviously, we have a place in any surgical environment, whether it's the operating room, cardiac cath lab, a GI clinic, OB, etc., etc. The surgical technologist is responsible for maintaining the sterile field, So this means that we have to have a thorough understanding of what we call sterile technique or aseptic technique, and we have to be able to apply it completely and confidently. All right, our patients' lives literally depend on this, because if we are not competent in maintaining the sterile field, we could inadvertently give the patient an infection wherever they're having surgery, and that could result in where they have to come back and have another surgery, or it could perhaps even lead to the loss of the use of a limb or the removal of a limb, or it could result in death. So it's very important. It's also important to note that we need to have an understanding of human anatomy and physiology, as well as the different surgical procedures. Do we need to know everything to go out there and function as a competent surg tech? No. This is a field that you're going into where you are going to be learning for the rest of your career, which is one thing that I really love about this field, is that it keeps me entertained, right? I haven't gotten bored so far, and I'm on year 25, so there must be something to that, especially if you're a lifelong learner. Then this is really going to be an amazing career for you. It's also important, I wanted to say, that each surgeon is also going to have their own unique way of doing things. And we're going to be expected to learn their technique. We have a saying in the field, maybe you've heard it already, but it's see one, do one, teach one. So we should be able to be on a learning curve that we see one procedure and then we can do it the next time, and then we can teach somebody to do it the next time. That is the expectation. See one, do one, teach one. So all of these components really help us to anticipate the needs of the surgical team and ultimately facilitate positive patient outcomes, which is the goal here. Now, as CSTs, we need to be professionals in our field. I think that kind of goes without saying. And to me, this boils down to competency, continued learning, attitude, our ability, and our dependability. It means that you can work as an effective team member too. After all, a person is literally laying down their life in front of you and trusting you know what you are doing and that you will exhaust every and all effort to keep them safe from harm and provide the best patient care. If you look on page 9 in your textbook, you'll see a list of actions that, when applied to our role as the surgical technologist, will help to ensure that we're competent. So what are some of those things? Well, continuing education is at the top of the list in our textbook. Again, I mentioned the importance of lifelong learning in your field as a surgical tech. Always continue to hone your craft. Hone your craft. Hone your craft. It's also important to be non-judgmental. Just because I might not choose to have a nose job or a rhinoplasty, somebody else might, and that's fine, right? We're there to provide patient care, not to determine should this patient have this surgery or not. That's not our role. So being non-judgmental is really important. Surgical conscience. Surgical conscience is the, what do you do when nobody sees you do something wrong? Do you make it right? Or do you just think, oh, well, nobody saw me do that, so I'm good? But it's not good, because that is going to have a domino effect down the line to our patient. So having a strong moral backbone, okay, that's our surgical conscience. We need to be able to have a voice and speak up for our patient. We are a patient advocate just as much as anybody else in that room is. And if we make a mistake, we need to be able to call ourselves out. And if somebody else is making a mistake, you need to be able to call them out too. I remember a time, article I read not that long ago about a surgeon who was charged with 10 counts of malpractice because he was cauterizing his initials into his patient's uteruses before he removed them. 10 counts. How does it get to be 10? That's my first question. My second question is, why didn't somebody say something? Surgery never happens with just the surgeon in the room. So you need to be able to find your voice. And if you're like me, I was very shy. I wasn't very outspoken. So this was more of a challenge for me. But I always kept the patient's best interest in the back of my mind. That is what encouraged me and gave me the courage to speak up. All right, I'll step down off my high horse there about honesty and kind of continue on. Respect for patient decisions. I think that kind of goes with being non-judgmental. Something that comes to mind is there are some cultures that do not want blood transfusions. And there might be the real possibility that somebody dies on your operating room table because they don't want blood when they could have been saved with blood. All right, so that might be something that happens. Ability to communicate effectively, we have to be able to communicate effectively. And on the flip side, know when to keep your mouth shut, right? We have 2 ears and 1 mouth, so we should be listening twice as much as we are talking, right? If we get too much into kind of the side conversations, we might miss something that we need to do for our patient. Willingness to serve on a committee. So pay it forward, teach others, serve on your assembly. AST has a state assembly for every single state. Consistent attendance and punctuality. We want to be there. We want to be there before we need to be there. Being on time is being late. We need to be there every day. We need to be there before we need to be there so that they know that they can depend on us, right? Maintain patient confidentiality. That's a big one. And then also willingness to learn and cope with change. All right, a word synonymous with the healthcare field is change. It's always changing and improving. Now we have artificial intelligence that we're using intraoperatively, and we have robots, and it's just going to keep progressing. And we have to be able to navigate those changes, all right, and roll with those. All right. Let's talk a little bit about these different organizations. On this slide, I say we are serving up some alphabet soup. Some important organizations that you need to be aware of regarding surgical technology education and certification are CAHEP, ABHES, ARC-STSA, and NBSTSA. So let's talk a bit about what each of those acronyms stand for. CAHEP is the Commission on Accreditation of Allied Health Education Programs, and ABHES is the Accrediting Bureau of Health Education Schools. So both of these organizations are responsible for ensuring that accredited programs continue to meet or exceed the standards of surgical technology education. Programs are not born accredited. Programs demonstrate competency and certain standards, and they are awarded accreditation, and then their job is to maintain those standards, okay? ARC-STSA, again, is the Accreditation Review Council on Education in Surgical Technology and Surgical Assisting. It's responsible for ensuring that accredited programs continue to meet or exceed the standards for education, all right? The NBSTSA is the National Board of Surgical Technology and Surgical Assisting. They award the credential of CST, and we want that, right? So how do we get that? To receive the credential, you have to be eligible for, which if you go to an accredited program, you are eligible to sit for the certification. So you have to have eligibility, demonstrate that, and then you have to pass it. All right, then you get the CST credential. Now, certification is not yet required in all states, but we are moving in that direction. Arizona is actually a state where certification is not required by the state. However, facilities are requiring it. It behooves us to get certified. What if we don't want to stay in Arizona all our lives? What if we want to go to New York? Or what if we want to go to Colorado? Both of those states require certification. So it's in our best interest to get certified, right? It demonstrates proficiency and competency in our role as the surgical technologist, and it often results in a higher hourly wage for us. It also increases marketability when you're seeking employment. So say this is the situation. There's you're a brand new grad, you're certified. There's someone else that has 2 years of experience and aren't certified. There's a good chance that you will be selected over them because you have your certification. So once you get your certification, you have to maintain it. To do that, you have to complete something called Continuing Education Units, or CEUs. The Association of Surgical Technology used to require 60 CEUs every 4 years, but recently they changed that to 30 CEUs every 2 years, right? So AST, we're going to talk a little bit about on the next slide. Here we are. That was a quick journey. AST, the Association of Surgical Technologists, that's our professional organization. If you haven't been to the website, be sure to check it out. All right, it has tons of information about us, right? That website is www.ast.org. So AST was established in 1969, and they work in conjunction with ARC-STSA. Remember, we said that they set the standards for education and certification. I also mentioned that each state has a branch of AST that represents their state. Get involved. Even as a student, you can go to the conferences that they have annually or biannually, and you can participate in that. It's usually at a lower rate. And they like students to be on the state assembly board as well. So you can definitely get involved there and contribute to your professional body. Like I said before, AST also publishes the core curriculum, which contains all of the components that accredited surg tech programs must teach in their curriculums. It can also be found on their website, the core curriculum, along with our job description and our scope of practice. And their mission statement is enhancing the profession to ensure quality patient care. They also are advocates for moral and legal duty and obligation to the patient. And you can read more about that on Table 1-4 in your textbooks. All right, here we are. We're going to talk a little bit about career opportunities as a surg tech. Primary ones on the left-hand side, you can see there in the little box, include hospitals, labor and delivery, and surgery centers. And sometimes we also call surgery centers ambulatory centers or outpatient centers. The difference between hospitals and surgery centers is that surgery centers, patients don't stay overnight. There's no beds. They get their surgery done. They go home a couple hours later. There are several other non-traditional career opportunities, such as materials management, clinical educator, surg tech faculty or program director, medical device representative, unit secretary. That's not an exhaustive list. There's actually more mentioned later on in the text for Chapter 1, so you could look at those. One of my past graduates, just 1 year after graduation, has actually moved into an OR manager role for a small surgery center. So there are a lot of opportunities for you to explore in this profession, which is super awesome. So let's talk a little bit about soft skills. So on the right side of your screen, this list is almost as long as the technical duties that we do, right? What I found in my 25 years of working in the field and managing a surg tech program, a lack of soft skills or as the book calls them, employability skills, is what typically results in a clinical site's decision not to offer you employment or to terminate you as an employee. So here's the thing. Technical skills such as gowning and gloving, scrubbing, passing instruments, they're much easier for me to teach someone than how to show up on time every day. Unless I literally go to their house and pick them up, which is a FERPA violation. Typically, when I receive a phone call from a clinical site wanting to remove a student, it is because of a lack of soft skills. So let this sink in for a minute. It's not because of their technical skills. It's because of their soft skills. Their soft skills. So let me give you an example. It wasn't too long ago that I received a frantic phone call from one of the OR managers at one of my clinical sites where I had a student. And I knew that wasn't good when I saw her name come up on my phone, because she doesn't just call to say, hey, your student's doing great. So I was expecting that something had gone wrong. I was hoping my student was okay. That was my first thought. I hope my student is okay. They didn't get poked or fall or get hurt or something. So she shared with me that my student had posted a very negative Google review about the hospital, and she wanted the student removed immediately. Soft skills, right? This was definitely not an effective use of communication. Other skills include dedication. We talked about that before. Our work ethic, being accountable, showing up, being there on time. Hey, folks, that's half the battle, right? Being adaptable. We talked about being able to kind of bend and flex with the changes that come along with the medical field. Conflict resolution. All right, we need to be able to resolve or de-escalate any situations. All right, you can't just punch a surgeon out in the middle of surgery, even though you might feel like it. All right, detail oriented. This is very important. All right, it's in the details that we really shine, right? As surge techs, being responsible. I think that goes back to accountability. Also, manual dexterity, being able to put things together and take them apart, kind of the understanding of that. Good vision, hearing, physical stamina. You're standing all day. You're leaning over a table. You're carrying heavy trays. You're moving patients, right? Not only is it physically challenging, it's also mentally and emotionally challenging. What if you have a patient die in surgery, right? Die on the table. That's a very real possibility. That's going to hit you where your heart is, right? Mentally, you get to your clinicals and your didactic training has taught you a million things. But guess what? There's still a million things that you need to learn, and you're going to continue to learn. So mentally, it can be exhausting as well. Again, the commitment to lifelong learning, and then our personal appearance. And it's sad that this makes the list, right? One school I used to teach at, we had to make a rule that the students wear underclothes. All right, we usually don't make these rules unless they need to be made. They don't really occur to us, right? So personal appearance, shower, be clean, all right? If you bartend at night, remember to take a shower so you don't smell like smoke and alcohol when you go in the next morning, all right? Groom yourself, look like you're put together, all right? If you need help with that, talk with someone, all right? I've had situations where my students didn't have access to hygiene products, right? And so they trusted me enough to come to me and say, hey, I need help, and we helped them, right? Get what they need. So make sure you get what you need if you do need something. All right, we're coming into the home stretch here. This is our last slide for this lecture. We'll talk a little bit about key characteristics of the surge tech. I have had students in the past that were so focused on memorizing the steps of a procedure. I can remember one gentleman, we were doing some tutoring together, and he's like, just write down the steps for me. Just write down the steps. Every single thing I need to do to pass when the surgeon's taking out a gallbladder. And that's good, wanting to learn the steps, but you have to realize that those steps are going to change. I mean, yeah, we're going to take out a gallbladder, but we might take a different pathway than we did in the last procedure. So that's good, but it can also put you as a disadvantage if it's your main focus. We as surg techs need to possess critical thinking and problem-solving skills so that we can navigate the situations that might arise. It's probably no surprise that two of the same surgeries are really never the same. And the anatomy might be different. You might be with a different surgeon that uses a different technique, or there could be bleeding or other unexpected situations that can arise at any moment, and we need to be able to anticipate so that we can get the surgeon what they need in a timely manner so that they can care for the patient. So the ability to think critically and problem solve quickly is really advantageous in the role of the surg tech. It provides us with the ability to prioritize and also consider other solutions, right? And then it's essential that we can work effectively as a team, in a team, even if we might not necessarily like your team members, right? You've probably all had jobs, or you have jobs. Perhaps there was someone that you didn't really care to work with, but you had to learn to get along with them. I can remember my good friend Catherine. She is the surg tech, and she was telling me a story about working at a facility, and there was this nurse that she really did not like to work with, and they were just struggling to get along. And so her boss brought her into the office, and she said, I am going to put you with this person every single day until the two of you can learn to work together. So we have to be able to navigate that, even if we don't, jump up and down for joy if we know we're working with that person, because at the end of the day, what's it about? It's about patient care, right? So we want to make sure that we are always focused on that. It's not about us. It's never about us. It's always about our patient. All right. So kind of the last little part of that is, in the problem-solving process, and this is typical of any time that you have a problem, you think of some various solutions to the problem, you choose one, you use it, and then you reflect. Did it work? Did it not work? Did part of it work? And then you revise, right, for the next time. I have an example. There was a situation where I was gathering the supplies for an ACL reconstruction. Now the ACL stands for anterior cruciate ligament. And it's this very large fibrous band that helps stabilize the knee. When we do these procedures, the surgeon uses a really strong suture to prepare the graft and then to replace the damaged ACL. And when I was gathering my supplies, I was unable to find the suture that the surgeon typically uses, and I was told that it was on back order, that we didn't have it. So if you were in my shoes, how would you handle this situation? For me, at first, I was worried about telling the surgeon, right? Because I thought he would be mad. The patient was already there at the hospital. Patients have to go through a lot of rigmarole before they get to us to actually have their surgery. And so they were there and they were ready. And, what I did was I just kind of drew on my experience that I had had with other surgeons, what I knew of suture materials, and I picked a few off the rack that I thought might work, and I went to him with some alternative solutions when I delivered the news. So I just basically said, we're out of this suture XYZ that you usually use, but here are some substitutes. And I just asked if he would be willing to use any of those instead, and he just said, thanks for letting me know, and he picked an alternate one, and we were good to go, and the crisis was averted. Sometimes it works out that easily, other times it doesn't. So those are situations that can arise that we haven't even planned for. And then, if you don't have experience, then find someone who does and ask them. All right, everyone, this brings us to the end of the first half of Chapter 1. So I hope you had some good takeaways and that you are falling in love even more with surgical technology like I have been for the last 25 years of my life. I appreciate your time and I thank you for listening.